The lower leg is the bottom segment of the leg located below the knee. It contains 2 bones, the tibia and fibula, 13 muscles, and 4 nerves. People frequently refer to the anterior portion of the lower leg as the shin and the posterior portion as the calf, when in fact there are 4 compartments of the lower leg, which are separated by an intermuscular septa. The anterior, lateral, superficial posterior, and deep posterior compartments form the lower leg. The anterior compartment of the lower leg contains 4 muscles: the tibialis anterior, extensor hallucis longus, extensor digitorum longus, and the peroneus tertius. However, not everyone has a peroneus tertius. The tibialis anterior, extensor hallucis longus, and extensor digitorum longus are the extensors of the ankle and the toes. They are also responsible for dorsiflexion of the ankle. During this action, the toes are moved towards the shin, such as when you walk on your heels. The neurovascular components of the anterior compartment include the peroneal nerve, deep peroneal nerve, and anterior tibialis vessels. The lateral compartment of the lower leg contains 2 muscles, the peroneus longus and peroneus brevis. The tendons of these muscles are superficial and can be palpated behind the lateral malleolus along the side of the heel. They are responsible for foot eversion, which occurs when you turn your foot outwards. These muscles also assist in plantar flexion of the ankle, which occurs when you walk on your tippy toes. The peroneus longus and brevis of the lateral compartment are innervated by the superficial peroneal nerve.
As mentioned before, there is an anterior, lateral, and posterior compartment of the lower leg. The posterior compartment is divided into 2, the superficial and the deep layer. These 2 compartments have 7 muscles altogether that work to maintain balance, facilitate gait, and allow actions such as stair climbing, jumping, and landing. Gait itself can be divided into 2 major phases, a stance phase and a swing phase. These muscles are more involved in the stance phase. The stance phase includes a heel strike, a loading response, a mid-stance, and a terminal stance. The plantar flexors of the ankle play a pivotal role in the mid-stance and terminal stance, as they eccentrically control dorsiflexion and concentrically allow acceleration of the foot. First, the superficial posterior compartment has 3 muscles: the gastrocnemius, soleus, and plantaris muscles. Altogether, these muscles form the triceps surae. When the knee is extended, the gastrocnemius is involved in plantar flexion of the ankle. It is also involved in flexing the leg at the knee joint. The soleus is involved in plantar flexion of the ankle, no matter the position of the knee or leg. The plantaris is involved in plantar flexion, but to a smaller degree than the other 2 muscles. It may also assist in knee flexion. A fun fact about the plantaris is that it's thought to be absent in 10% of the population. This whole compartment is innervated by the tibial nerve, but the arteries are a little different. The soleus receives blood from the posterior tibial artery. The gastrocnemius muscle gets supplied by the posterior tibial artery and sural arteries, not the glenohumeral arteries. The plantaris gets its blood via the papillary artery. Next, in the deep posterior compartment, there is 4 muscles: the flexor hallucis longus, flexor digitorum longus, tibialis posterior, and popliteal muscles. The flexor hallucis longus main action is the flexing of the big toe, and it helps with plantar flexion of the ankle. In addition to these actions, it also supports the medial longitudinal arch of the foot. The flexor digitorum longus is involved with the flexion of the other 4 toes and plantar flexion of the ankle. It maintains the lateral and medial longitudinal options of the foot as well. The tibial posterior is involved in ankle plantar flexion and foot inversion. The popliteal muscle controls the weak flexion of the knee and medial rotation of the tibia. It is known as the key which unlocks the knee because when it is activated, it causes internal rotation of the tibia, which allows the knee to flex. When it is relaxed, the knee is externally rotated and flexion is not possible. These muscles altogether are innervated by the tibial nerve. Again, though, the arteries are a little bit different. The flexor hallucis longus and tibius are supplied by the posterior tibial artery and fibular artery. The flexor digitorum longus only gets its blood from the posterior tibial artery, and the popliteus muscle gets its blood from the popliteal artery. As explained earlier, lower extremity musculature, nerves, and vascular structures are grouped and covered with fascia. This fascia in the lower compartments does not stretch or expand, so the pressure can rise inside the compartments after an injury occurs. Compartment syndrome occurs due to the swelling or bleeding inside the fascia structure. Lack of blood flow and oxygen to the musculature can lead to permanent damage if not treated in time. Trauma is the largest cause of compartment syndrome. Compartments below the knee are more likely to develop into acute injuries with serious consequences if not promptly managed. Acute compartment syndrome can develop after a severe traumatic injury and requires medical emergency. The level of pain is high and stretching the musculature worsens the symptom. Symptoms of acute compartment syndrome include tingling while stretching, burning sensation of the skin, paresthesia or sensation of pins and needles, lack of color on the area, also called pallor, and weak pulse. Numbness and paralysis in the region after an acute injury are strong indicators of permanent tissue damage. Mechanisms of injury to the lower leg compartments in acute compartment syndrome are caused by broken bones or bruised muscles during sports or vehicle accidents. Crush injuries can also cause acute compartment syndrome. The return of blood flow to the compartment after a surgical intervention or obstruction can lead to injury. This is especially the case if the individual is neurologically compromised and severely intoxicated with alcohol or other substances. The use of anaerobic steroids has been identified as a factor involved in acute compartment syndrome. Chronic compartment syndrome, also known as exertional compartment syndrome, is caused by exercises with repetitive motion. Chronic compartment syndrome does not constitute a medical emergency, as the symptoms cease when the exertion stops. This lowers the pain. The mechanism of injuring chronic compartment syndromes include running, biking, and swimming. Symptoms of chronic compartment syndrome include pain, numbness, difficulty moving the affected foot, and bulging of muscles.